Dear friends, today I'll be discussing how to learn neuroendoscopy. This talk is designed to help beginners who are just starting in the field, though some point may also be useful for those who are already practicing neuroendoscopy. The concept of learning neuroendoscopy highlights the need to overcome the limitation to master the technique. I introduce a D curve in Scott's learning parabola, which include stage A, that is idea of the new technique, stage B, initial enthusiasm from its advantage, C, decline in the enthusiasm due to limitation, where many of the colleagues discontinue endoscopic treatment because of the complications associated, because there are limitations in the endoscopic technique. D is mastery achieved by overcoming limitation through continuous learning process. So learning neuroendoscopy is equivalent to overcoming limitations. Another very important thing in endoscopic learning is we must understand the Dunning-Kruger effect, which reminds us that learning is not just about gaining skill, but it is also about the accurately recognizing our capability. The beginners often feel overconfident. Intermediate learner may be underestimating themselves. True expertise brings both competency and humility. So structured feedback and mentorships are therefore essential to guide learners through this curve, helping them progress from initial overconfidence through self-doubt to the genuine mastery. Here in this curve you can see that this is the increasing knowledge and experience, and this is the confidence. So when the knowledge and the experience is very little, the learner may be overconfident. So this is known as peak of Mount Stupid. Gradually when you keep learning, then you get complications, and then you realize that you know very little. Overcoming limitations will give mastery, and mentorship also guides you by giving proper feedback of how individual person is progressing in the learning process. Let us now discuss general principle of neuroendoscopy. White balancing is done at the start of each procedure using a white object under proper light, ensuring accurate color and consistent image quality. For proper white balancing, the entire endoscopic field should be filled with pure white object, avoiding situation where only the part of the field appears white and rest shows other color. In that case, white balancing may not be correct. This video demonstrates that for proper white balancing you should have full view as white, and one should avoid half white and half other color. Camera orientation is maintained by keeping the button facing the monitor, verifying with the directional movement of up, down and lateral side, placing monitor opposite the surgeon and checking for the rotation during surgery. Camera orientation is checked by left, right and up, down movement. Left, right, up, down movement of camera with the endoscope should correspond with the movement occurring on the monitor. So this is the video showing camera orientation. Move it to the right and left and up and down. It is very important to use focus button to bring the desired object into a clear view, ensuring that it lies within the focal length of the endoscope. The image will appear blurred if the focus is incorrect or if the object is outside the focal length. This video demonstrates that in the beginning you are not able to see things properly because it is out of the focus. When you bring the scope near to the object or zoom it, if it is lying in the focal length, then one sees the object very clearly. So it is very important to focus. Instrument design is important. Straight and round shaft are preferred over bayonet and flat shaft instruments. The instrument tip should be slightly curved, as this provides better visualization compared to straight tip instruments. The precision grip, using a tripod-like grip with thumb, index and middle finger providing stability, minimizes tremors, allows fine control, making it essential for delicate neuroendoscopic tasks. In contrast, power or piston grip relies on larger muscle group to apply force, but it sacrifices accuracy, increases tremors, offers poor support. Precision grip is best for safe and control work. So this is the precision grip. The hand is supported. This is power grip, hand unsupported. So if you have to use power grip either because of the poor instrument design or because you have to need force, in that case the precision grip should be combined with the power grip. Hand support is also desired to prevent fatigue and improve precision. It can be achieved by hand support on working channel or on the cable. Here you see the hand is supported on the cable. Here it is supported on working channel. In this case, the hand is hanging unsupported. In long surgery, it will give rise to fatigue and increase chances of tremors. As mentioned in the beginning of this talk, learning neuroendoscopy largely involves overcoming its limitation. Therefore, it is important to understand these challenges. The limitations of neuroendoscopy includes blind area, difficulty in controlling bleeding, restricted by manual dissection, short focal length, loss of orientation, poor visualization, the need for unique endoscopic skill, and reliance on 2D imaging and a steep learning curve. Blind area can occur at various points in endoscopic technique. This is the endoscope. Anything proximal to the endoscopic tip is also blind area. This is denoted by A area, and anything which is in a straight line, whether in the deeper plane or in the same plane as the endoscopic tip. So this is the endoscope, and if there is some instrument, the point B will not be visualized, and same way point C also will not be visualized. There are strategies which can help avoid blind areas, and these are: first is remove the scope before inserting instrument when surgeon or assistant is holding the scope. Second, insert instrument under direct vision until it appears on the monitor when a scope holder is used. Third, use working channel or tubular retractor to protect tissue and avoid injury proximal to the lens tip in the blind area. Fourth, withdraw the scope slightly away from the target to allow the instrument to enter in the field gradually, minimizing the risk of accidental injury. So here is the point 1. So when you want to introduce instrument, take out the endoscope, and the instrument tip should be about 1 centimeter ahead of endoscope. Second, when endoscope holder is used, then in that case, until the instrument appears on the monitor, that means it goes beyond the lens tip. In that reason, you should be watching the instrument entry by the naked eye. Third, in the endoscopic surgery, we all are aware that anything proximal to the endoscopic tip will not be visualized. So when you introduce instrument in this blind area, there may be injury to the brain. Keeping a tubular retractor will protect the surrounding brain from injury. If you pass instrument through the working channel, that also protects. Instrument coming suddenly from the working channel can injure the field very close to endoscopic tip. For example, in endoscopic third ventriculostomy, If your endoscope is very near the floor of third ventricle, the forceps which we introduce can suddenly bump into the floor of third ventricle, injuring the floor. So the ideal thing is that you should withdraw slightly away from the area of interest, so that when you introduce instrument well ahead of target, you can visualize the instrument which is being passed. This is an example of how to introduce instrument when surgeon is holding the scope. With each introduction of instrument, you should keep the instrument about 1 centimeter ahead of endoscope, and both instrument and the endoscope should be gradually introduced until you see working area very clearly. Withdraw the scope slightly away from the target to allow instrument tip to enter the field gradually, minimizing the risk of accidental injury. This is the video of how to introduce instrument through the working channel. Withdraw the endoscope slightly away from the target area. For example, the floor of third ventricle. Once the instrument comes in the view, then you gradually advance it towards the area of interest. But if you are very close to the surgical target, then the instrument can accidentally enter and suddenly perforate the floor, causing injury. Practical nuances in tissue dissection. One should move the tissue sideways to expose the deeper structures, which could be artery or the nerve, rather than pulling it towards the scope. In this diagram, one can see that this is the endoscope. This is the tissue which surgeon wants to dissect. There may be some artery or the nerve. One should gently dissect it to the side, cranial, caudal, medial or lateral, but one should not pull it towards the endoscope. If tissue is pulled toward the endoscope, the area deeper to it, that is the nerve or vessel, may get stretched and may get injured without knowing it. This is practical demonstration of moving tissue to the side to avoid injury to the deeper structures. This gauze piece simulate tissue, and the red structure simulate the vessel. So one should move it to the side so that you can see the tissue as well as you can see the vessel, dissection from the vessel underneath, deep vessel, which can be preserved. On the other hand, if you pull it towards the endoscope, the deeper structure is not visualized. This can get stretched or can get torn. Maintain a triangular arrangement to avoid blind area. Avoid a straight arrangement. These are the examples, diagram showing endoscope, instruments, and the surgical target in the triangular arrangement. So with the endoscope, you can see instrument and you can see target tissue. If the arrangement is linear, the endoscope here, instrument, and the surgical target, in that case, the target will not be visualized. Same way, this is the endoscope, this is the cutting edge of the Carrison punch, foot end, the simulated lamina, which is ice cream stick. So all three are seen: cutting edge of the Carrison punch, the lamina, the undersurface of lamina. Whereas if there is a straight arrangement between the foot and cutting or the lamina, then the cutting edge is not visualized. The distal lamina also is not visualized. This is practical demonstration of how a triangular arrangement of Carrison punch cutting end, its foot plate part, and the endoscope allows clear visualization of cutting edge and the simulated lamina. In contrast, a straight arrangement obscures the punch cutting tip and the lamina, making safe removal difficult. This is a video showing two laminas. This is interlaminar window. Of course, it is a simulated model. The ice cream sticks are used as lamina. Carison punch introduced in such a way that the cutting edge is seen because of the triangular arrangement. The cutting end of the Carison punch is pushed under the lamina under endoscopic vision. It is rotated back, and then the part of the lamina is removed. On the other hand, if a straight arrangement is there, the foot end of the Carison punch is visualized, but the cutting end of the Carison punch is not visualized, which will make laminectomy, that is removal of the lamina, difficult because the cutting edge is not seen. This is a diagram showing how the forceps which has two jaws should be used in the endoscope. This is the endoscope. These are the two jaws of the forceps. They should be placed in such a way that both jaws are seen, and through the space between these two jaws you can also observe the surgical target area. Whereas if you align forceps in such a way that there is a straight arrangement between endoscope, the forceps jaws and the surgical target area, then the distal jaw and the surgical target will not be visualized. This is the practical demonstration of how to use forceps with two jaws for tissue dissection. This is the seed which can be simulated as a tissue. The forceps introduce parallel arrangement, not visualizing the distal jaw, and the tissue rotation of the forceps brings both jaw in view, and the tissue also is visualized, and then you can take it out. This is the diagram which shows how the instrument should be introduced. This is the endoscope, this is the instrument, and this is the surgical target area. So if you introduce in such a way that the instrument comes between the endoscope tip and the surgical target area as shown here, then the surgical target area will not be seen. Whereas on the other hand, if one brings the instrument from the side and then bring it to the surgical target area and then dissect this tissue, then the instrument is visualized as well as the surgical target is also visualized. This diagram shows how there should be arrangement between the bleeding point, the patties, and the endoscope. Triangular arrangement allows visualization of the patties and the bleeding point, but if the scope and the patty and the bleeding point are in a straight line, then the bleeding point is not visualized and you cannot place it exactly on the bleeding point. Whereas in this case with triangular arrangement, if you bring it from the side, you can keep watching the bleeding point and put it at a correct place. However, there are situations where there is a narrow corridor, such as partial corpectomy, and in those situations, straight arrangement cannot be avoided. We have come across such situation. This is a partial corpectomy. This is the vertebral body and the bone removal done for partial corpectomy. If you place endoscope here, there is hardly any space for triangular arrangement. So you have to keep two instruments in a straight line. You have to keep endoscope here. You cannot put it the other way. If you put it away from there, then the floor will not be visualized. So you have to keep endoscope, the drill, and the suction in a straight line. What to do when you put drill, the third instrument, that is the suction, will not be visualized. I suggested that distal instrument should be introduced first under vision, keep it at fixed depth so that it keeps on sucking, and then you can introduce proximal instrument. In a dry field, you can drill the compressive bone and do the decompression. So one can use both suction and the drill at a time in a straight line, avoiding blind area. This was described for the first time by me. This is a practical demonstration of working in a straight line to avoid blind area using a simulation model with a narrow gap simulating partial corpectomy. The procedure is performed with an easy go. We can see this is the gap, this is the margin of the vertebral body. When we introduce Carison punch, that is proximal instrument, the distal instrument is not visualized and then you cannot place it at a correct position. It may injure cord in the blind area. On the other hand, if we put distal instrument first, suction first, and keep it at a definite place, then we can use Carison punch effectively and do the decompression and achieve cord decompression properly. This is the teaching video demonstrating the effect of triangulation, emphasizing the correct use of triangular rather than straight arrangement. It also illustrates proper handling of Carison punch, the forceps with two jaws, and correct placement of patties on bleeding point. This is the teaching video, the Carison punch, triangular versus straight arrangement. Now, a straight arrangement does not allow visualization of cutting edge, whereas triangular arrangement allows visualization of cutting end and the undersurface of the lamina, avoiding dural tear. Forceps, how to use them. Triangular arrangement of the two jaws, allowing both the jaws to be seen and the tissue in between. On the other hand, if a straight arrangement is done, then distal jaw is not seen, the tissue is not seen. Again, triangular arrangement versus straight arrangement. If we put patties in between the endoscope and the bleeding point, then the bleeding point is not visualized. You cannot correctly place the patties. Whereas if you bring it from the side, making some angle, then you can bring it to the correct position. The obstruction during instrument manipulation can occur due to three things: the endoscope, the port or the tubular retractor, and the instrument itself may cause instrument manipulation obstruction. Endoscope related obstruction, the scope can limit instrument movement when placed centrally, or when a sword effect occurs, that is, the scope and the instruments are directed in the opposite direction to each other. Avoid this. We should position the endoscope at the periphery of the field and align it in the same direction as the instruments. The port may block instrument if its axis is in opposite direction to the surgical target, again creating a sword effect. Aligning the port and the surgical target in the same direction helps in maintaining a smooth access. The other is the instrument related obstruction. Thick and straight instrument may hinder the movement of others, especially in the narrow corridor where multiple instruments are required. Linear movement may not be feasible. Instead, use thin instrument with angle tip, preferably multifunctional design. For example, suction with irrigation, coagulation, and aspiration. Rotating the angle tip instrument is more effective than linear movement for reaching the corner of the field. The scope may restrict instrument movement if placed centrally and when it is placed very close to the surgical target. On the other hand, positioning it at the periphery and away from the surgical target tissue improves instrument manipulation. This image explains this is the endoscope, this is instrument, this is the surgical target. So if the endoscope is placed in the center and very close to the surgical target, then the instrument manipulation will be hindered by the endoscope itself. On the other hand, if the endoscope is placed at the periphery and away from the surgical target, the instrument manipulation will be very easy. The image A shows sword effect by placing endoscope and instrument in the opposite direction. It obstructs instrument manipulation, whereas aligning them in the same direction to the surgical target improves maneuverability as shown in B. So here, this is the endoscope, this is the instrument, this is the surgical target area. If these are aligned in the opposite direction, causing a sword effect, then instrument manipulation will be difficult. Whereas on the other hand, if the endoscope and the instruments are aligned towards the surgical target area, when there is no sword effect, then instrument manipulation becomes very nice. The endoscope should be oriented according to the planned direction of dissection. It should be cranially when the target lies cranial as shown in A image, to the right side for right-sided dissection as shown in B image, and similarly caudally or to the left side as required. It should not be placed too close to or directly on the target as it is shown in C, because this restricts instrument manipulation. Instead, placing it slightly to the side or above or below the target provide unobstructed working. This is explained in this image very well. This is the surgical target area, the place where you want to work. This is the endoscope position. So if the surgical target area is cranially placed, your endoscope also should be cranially placed. But it should not be directly on the surgical target area. If you put your endoscope here, then the instrument manipulation to the surgical target area will be obstructed. So it should be on either side. You can put it on the left side or right side, but it should be cranial. It should not be here. This is the ideal situation. It should not be here also. If you put endoscope here and if you bring in instrument for dissection or for drilling, then the surgical target area will not be seen. Same way, if the surgical target area is on the right side, then your endoscope should be slightly to the up or down, but not opposite to this area. It should not be on the left side. This is a video showing how angled instrument allows instrument to be used right up to the corner in all four directions. So using angle instrument, you can reach all the corners and you can even reach beyond port. So the angle instrument allows the greater reach, whereas if you use a straight instrument, this is the straight instrument, the surgeon is trying to bring it to towards this side where the endoscope is. The endoscope is trying to obstruct the instrument to reach at this area. If you use straight instrument, this is the limitation. So there are only two ways. One is that you should use angle instrument. Angle instrument can go there, or rotate the endoscope to the side. If you bring endoscope to this side or up, then you can bring even the straight instrument there. But it is better that you use angle instrument. This image shows that instrument manipulation becomes difficult when port and surgical target are aligned in the opposite direction. On the other hand, it becomes easy when both are aligned in the same direction. Here one can see that the surgical target area is on the left side, but the port is aligned towards the right side. So this causes sword effect, and there is a difficulty in manipulation of instruments in such situation. Whereas in this picture, one can see that the surgical target area is on the left side. The port is also aligned on the left side. Therefore, in such situation, the instrument manipulation will be easy. This slide shows that the thick and straight instrument restricts movement, whereas thin and angle tip instrument enhance mobility. Instead of linear movement, rotational movement with angled instrument should be used. Angle tip instrument allow access to the corner, and articulating forceps with ratchet provide additional reach to the corners. In this image, you can see that there is endoscope and there are two thick instruments, and therefore the instrument manipulation becomes difficult. On the other hand, if the instruments are thin, they will occupy less space and the instrument can be manipulated reasonably easily. In this particular image, one can see that the endoscope is nicely placed at the corner, but there is a suction and there is another instrument. So presence of suction will also obstruct instrument manipulation in this particular narrow corridor. If we use angle tip instrument, then this angle tip can reach all the corners of the corridor. Similarly, if an instrument which has articulating forceps with ratchet, so that also allows more control, and you can angle it at a different angle and reach the object at different position in a narrow corridor. We have seen that the instrument manipulation is difficult when the alignment of endoscope and the port is wrong. Situation is much worse when both endoscope and ports are oriented in the opposite to each other. Aligning port, endoscope and instrument in the same direction improves mobility. There are many causes of poor visualization, and there are solutions also. Out of focal length is one such cause of poor visualization. In such cases, adjust the focal length to achieve the sharp image. Humid air and fume can cause poor visualization. In such case, suction of the air or fume improves visualization. Blood, fluid droplet or bone dust on the lens tip also cause poor vision. Keep the scope at an adequately far distance. Use zoom function or large diameter scope to prevent swelling during drilling, and perform intermittent irrigation during drilling to minimize lens swelling. Suctioning of blood by the catheter placed in the working channel draws blood towards the lens tip, which obscure vision. In contrast, if the suction tip is placed beyond the lens tip, it prevents poor vision. Brain tissue contacting the lens tip is another cause. Place a silicone tube between the scope and the brain tissue to avoid lens swelling. Scope alignment opposite to the surgical target is another cause of poor vision. Align the the scope in the same direction as the target for optimal visualization. Improper scope to monitor connection or damaged scope are the another causes. Ensure proper connection and replace or repair defective equipment. There are general measures. One can use anti-fogging agents, lens cleaning solutions, or saline irrigation with suction to maintain a clear view. This is a short video showing how fluid, humidity, and fumes can cause poor visualization, and suctioning them improves vision. This is a good visualization. Now the drop of fluid cause poor vision. You cannot see anything. So suctioning the fluid by suction on the tip improves vision again. Fume also or humidity also causes same blurring of vision. So you suck it with the suction tube and the vision improves. 2D neuroendoscopy is another limitation. It lacks depth perception, making distance judgment, coordination, and orientation difficult, which slows surgery and increases the risk. The solution includes 3D endoscopy, augmented reality, navigation aids, simulation training, robotic assistance, lighting and shadow effect for the depth cues, and angle instrument. Lighting and shadow effect can be created by angling the scope. In such cases, bright image and the shadow or less lighter image gives idea about the depth. The orientation difficulties in neuroendoscopy arise from improper camera placement, rotation, limited field of view, which shows only part of the structure, obscured landmarks, and inadequate anatomical knowledge. The solution includes correct camera positioning, aligning the camera head towards the monitor, frequent orientation check, de-zooming for an overview, confirming anatomy before dissection, thorough knowledge of anatomy, and using navigation or AI when landmarks are unclear. Neuroendoscopy has a steep learning curve with challenges in transition from microscope to endoscope due to bleeding control, blind area, 2D vision, instrument handling in the limited space, orientation issues. The solution includes structured training, starting with the simple cases to progressively doing more complex cases, not doing complex cases in the beginning. Multidisciplinary teamwork, taking help from other specialists and colleagues, practice on model, cadaveric dissection, simulators, lab training, and live workshops. Mastering neuroendoscopy requires developing dedicated endoscopic skill in addition to conventional microscopic surgical expertise. The two techniques differ greatly in principle, instrument handling, and visual orientation. Here one can see that learning neuroendoscopy requires development of microscopic skill as well as endoscopic skill. So that means even if the person is expert in microscopic skills, he or she has to also learn endoscopic skill, which are sometimes completely different from microscopic skills, which I'll discuss in the next slide. These are the differences between microscopic and endoscopic technique. In microscopic surgery, bayonet-shaped instruments are standard. The target is centered in the field of view. Microscope offers a wider, unobstructed operative corridor, enabling smooth instrument manipulation and drilling without visual field being physically occupied by the endoscope. Orientation is stable, blind areas are rare, and control of brisk bleeding is generally easier since blood does not soil the lens. The entire operative field is available for instrument use, and 3D visualization enhances depth perception, precision, and safety. Endoscopic surgery, however, demands distinct visuospatial and technical skill. Non-bayonet instruments are often preferred for smoother handling in narrow space. The target is best positioned at the corner of the visual field to avoid obstruction from endoscope itself. Blind areas are more common, especially with suboptimal alignment, and frequent camera rotation can alter orientation. Working corridor is partially occupied by the scope, restricting instrument mobility and complicating drilling and dissection. Controlling brisk bleeding is more challenging as lens swelling can rapidly obscure the view. While 3D endoscope exists, most systems still provide 2D images, limiting depth perception and placing greater demand on hand-eye coordination, spatial awareness, and instrument control. We have devised a simple and inexpensive module for basic endoscopic skill training. All basic skills such as deep and superficial operative area training, suturing, dissection, hemostasis, and cutting can be learned in a cost-effective way. This is the model. This is made of earthen pot which is used to drink tea, and the hole is made at the back side of it and it is fixed. So through the hole one can practice surgery. The simple camera and the LED light source is attached on the back of this, and these camera and LED light source are connected to the laptop. After that, different exercise can be done, and one is dropping the rubber band on the pin without touching the adjacent pin. So the pin are arranged in 1 to 9 fashion. First one can drop the pin at number 1, then at number 9 and 3 and 7. Then you can do it diagonally also, the way you want, without touching the surrounding pins. The other exercise is laminectomy using Carrison punch. Lamina is simulated by the ice cream stick. Marking is done using a Carrison punch. On the defined margin, ice cream stick is nibbled. The third exercise is using a scissor on a square or any definite shape, and this line you should exactly cut on that point. So different endoscopic skill can be learned using this simple inexpensive model, and this can be used in one's office also. Operation theatre facilities are not required. Liu et al. Designed a cardboard box which was divided into 3 sections, each designed for a specific exercise. Large beveled straws in blue, green and brown colors are positioned to learn orientation from superficial to deep areas. The task included touching the marked black dots on each straw, and the time taken is recorded. For another exercise, cotton balls are taken under endoscopic control to reach the target point on the straws, and again the completion time is recorded. For fine control, marker pen is attached to the endoscopic sheath and is used to trace the shape such as triangle, square or circle on the blackboard, staying about 5 millimeter inside or outside that particular shape or the letter. This is a cardboard which is divided into 3 portions. In one portion these straws are placed. These are at different levels. These are superficial, These are deep also and of different colors, green, blue and brown, light blue, and the black marks are placed superficially and deep also. Instrument should be taken and touch the black points superficially and deep, and one should be able to negotiate between these two straws. So with this one can learn hand-eye coordination. The next exercise is that the cotton ball is taken and should touch these black points on the straw. This also will give us hand-eye coordination. In another exercise, the pen is used to mark different shapes, triangle, quadrangular, or A or B or any other shape. Outside or inside these marking, one should draw these shape. This will give fine control. We use GOAT model for endoscopic transnasal training. For visualization, a boroscope with 5 centimeter rigid distal segment is attached to 18 centimeter long wooden stick to simulate a rigid endoscope. This allowed better positioning of the scope. Training was performed using the right and the left nostril of a goat head. The key structures such as concha ventralis, concha nasalis, media, septum, and choana was visualized. After removing the concha ventralis and part of concha nasalis media, the sphenoid ostium and choana become visible. By breaking the posterior 1/4 of the nasal septum, bimanual work was possible, similar to human being. Further removal of anterior sphenoid wall exposed the sphenoid sinus and central sphenoid septum, closely resembling human anatomy. This model provides a valuable training alternative when cadavers are not available. This is a boroscope. This is the distal end of the boroscope, and this distal end of the boroscope is attached to the wooden stick. This simulate the rigid endoscope, and with this the GOAT nasal anatomy is studied. Drilling and dissection can be performed very effectively. This is alternate to a cadaver because cadaver models are limited. We also devise a physical simulator using an iron pipe of 2 centimeter diameter. It is 8 centimeter long to represent the nasal cavity. In its initial 6 centimeter top, the pipe was cut open, leaving the distal 2 centimeter intact. Straight plate is inserted through the cut end to divide the pipe into two channels, simulating the right and the left nasal cavity. The single portion allowed a bimanual approach. A wooden spoon with a boiled egg was positioned just beyond the distal pipe to mimic the pituitary gland, providing a setup for drilling and dissection. This is a physical simulator. This is an iron pipe and it is fixed on a stable stand. This is 2 centimeter in diameter. The initial 6 centimeter of this pipe, the top end of it is cut, and through this a plate was inserted. This plate simulated nasal septum, which divided this pipe into two, right and left, simulating left and right nasal cavity. The distal 2 centimeter of this pipe does not have septa. So that means that will allow us to go for bimanual dissection. Distal to this pipe, we kept a wooden spoon with boiled egg attached to it, which could be used for drilling and dissection, simulating the bone and the pituitary gland and the tumor. Apart from technical difficulties in learning endoscopy, there are non-medical or systemic barriers. I have also suggested methods to overcome them. The first is workforce shortage. structured residency program and international partnership to expand the exposure is required. The other one is limited access in resource constraints setting. International partnership, mobile training units, and low-cost lab and simulation models are the answer. Equipment cost is also a limitation. Low-cost innovations, collaborative and share equipment use, and improved reimbursement policies are needed. Lack of proper instruments and durability issues, improved access to the equipment, development of affordable alternatives, proper handling training to avoid premature failure, reimbursement and long-term comprehensive maintenance and backup system is needed. Lack of training and inadequate exposure is a problem. Curriculum integration into residency and fellowship programs, training at high volume centers and international fellowships are required. Lack of mentorship and fear of complication is another problem. Structured mentorship program, proctoring by experienced surgeon and remote guidance is needed. There is also a lack of evidence and efficacy doubts in endoscopic surgery. High quality research, multi-center studies, outcome registries and guideline developments are required. Increased operating time and technical difficulties are another problem. Simulation based practice, high case volume exposure, ergonomic enhancement, three-dimensional endoscopy and augmented reality guidance can to some extent overcome this problem. Complication management is another issue. Mentorship, structured complication management workshops, backup support systems are essential. There are also early career challenges which need institutional onboarding support and phase practice setup. Lack of support staff and administrative backing is another problem. Administrative and staffing support during early practice and leadership awareness programs should be done. Infrastructure and resource gaps, targeted investment and persistent with gradual skill acquisition is the answer. I am grateful to my teachers. This presentation is dedicated to my great teacher, Professor V.K. Kak. Thank you very much.